Welcome, and this is another in the series of kind of just an add-on to the classroom presentations. And today I want to talk a little bit about neurological emergencies, very specifically altered mental status, seizures, and syncope. As we always do, we start our presentations by going over our objectives, and we want to define altered mental status. And I'm not just going to give you a textbook definition of it, but more really what we're going to do is go through scenarios, especially scenarios based on seizures that kind of can clue us in on altered mental status. We're going to talk some of the common causes of altered mental status, and that is really going to focus on our AEIOU tips. We're going to go through seizures and status epilepticus, and then some of the complications associated with those seizures. Now, when we talk about neurological diseases, like most diseases or conditions, they're caused by more than just one factor. Disease susceptibility, especially when we talk about neurological diseases, often relates to development in utero before we're even born, as an embryo, as a fetus, our development then. It all through a scenario. So you're working on a BLS engine, and you get toned out for a woman who's unresponsive, and the dispatch information tells you that she's having clonic activity, and she's having seizures, convulsions. And when you get on scene, you walk in, and this is kind of what you see. You see a young woman laying on the floor, and yes, she is convulsing. She's repeatedly striking her head against the floor. Well, first thing, you obviously should immediately assure that you have a safe scene. Make sure you have your PPE on. Make sure that you have adequate resources. And since you're on a BLS engine, you might want to at this time consider an ALS rig responding. You also want to, figure out how many patients you have. Well, just looks like the one, and get a general impression. You're in a nice house. The patient looks like they're having convulsions. And the next thing you need to do is, well, assure the patient stops striking her head on the floor. Either gently hold her head or place something under it. While you're doing that, the family tells you that she has a history of seizures and is prescribed Dilantin, but they're not really sure if she's been taking it or not. So we'll come back to the scenario. We'll come back to it. I just want you to think about it for a few minutes. But as we start going into when we have a patient with an altered mental status, and I want to talk about altered mental status real quick. Oftentimes the altered mental status that we're presented with are very subtle alterations in mentation. They're not necessarily not profound, like in this case we just saw, but they can be very, very subtle. And we have this little mnemonic to help. The first thing the A gives us is to consider alcoholism. Is alcohol maybe the cause? And acidosis. Remember in our lectures we told you that the body can perform well at a very narrow range on the pH scale, only from about 7.35 to 7.45. So could something have thrown their acidosis off? Could they be very either alkalotic or very acidotic? When we look at the E, we start thinking of multiple things. Could it be an endocrine problem? And now the first endocrine problem most people think of is, well, maybe their blood sugar's out of whack. But it could be other things. It could be Addison's disease, a disease of the adrenal glands that has some very, very specific presentations. Could it be environmental? And that goes kind of a long range on it. Could there be something in the environment that caused them to have this altered level of consciousness? Could their electrolytes be totally out of balance? And then could it be epilepsy? Could they be having an epileptic seizure? Well, insulin. Again, taking us back to that endocrine, but very specifically focusing in, could the patient have taken too much of their insulin and be hypoglycemic, or could they have not taken their insulin and a type 1 diabetic now being in DKA? So we have to kind of throw in the diabetic portion of it. Well, Could they have had an overdose? Could they have had an overdose of prescription medications or non-prescription medications? Could they be hypoxic? Could they be low on oxygen? Could it be an opiate overdose? Could they have used fentanyl or heroin or carfentanil or one of the many other opiates that are around? The U is pretty much one thing on the U. Uremia. Could they be in kidney failure? And secondary to the uremia, could they be having uh, a altered consciousness? T, trauma. And I didn't put it on here, but we got to kind of throw in toxins also, but we kind of grab that in just a few minutes. So the T for trauma. Could they have sustained a head injury? I is one we need to think about a lot. That's infection. Could the patient potentially be septic? And then P, back to our poisons, kind of the toxin side of it. Could they have gotten into something, say an organophosphate poisoning that has given them an altered level of consciousness? And we can't rule out psychogenic. Could the problem be a psychogenic origin? And then finally, S is kind of our big one. Could they be in shock? Could they have had a stroke? Could they have had a syncopal episode? Could they have had a seizure? And then kind of relaying back up to the I part, could they have an infection? Patient who, you know, we probably should narrow it down. We might think about hypoxia and a seizure and stroke and a diabetic emergency or maybe some other serious medical issue, but we've already been given some pretty good clues, right, from both the scene and physiology of seizures. What a seizure is a sudden erratic firing of the neurons in the brain. It's an electrical storm in the brain, for kind of lack of a better term. Signs and symptoms, well, those muscle spasms, copious amounts of secretions, and the patient's going to be hypoxic and very possibly turn cyanotic. If we have an extended seizure, we have some greater concerns. We have low cerebral glucose, and the patient becomes very, very hypoxic. So we have to worry about brain damage secondary to these long seizures. Now, seizures do kind of follow a pattern, especially when we're talking about grand mal seizures, convulsive seizures. Sometimes, not always, and not with every seizure, but the patient will have an aura. They'll have a warning that a seizure is coming on. They may see lights. They may have an odd taste in their mouth. They may smell something odd. They may start twitching. Then very quickly you have this loss of consciousness, this tonic phase, and this hypertonic phase. And oftentimes when you get a description of a seizure, they'll say, well, they grunted right before they hit the ground. That grunted is that hypertonic phase where their muscles lock up. And then we go into the clonic phase, the seizure phase. And depending on the person and the type of seizures and their history, that actual seizure phase lasts anywhere from 1 to 3 minutes. At the upper extreme of it, maybe 4 or 5 minutes. And then the post-seizure, after the seizure, they become in a situation called post-ictal. So kind of remember, this person's had an electrical storm going on in their brain. And that post-ictal period is the resetting of their brain. So let's go to another scenario. So your crew's out. You're on a BLS engine, and you go do some PR work at the local grade school. You're doing a presentation on Halloween safety, or as we go into the summer, maybe it's bike safety or swimming safety or something like that. But you're doing a presentation, and you ask everybody if they have any questions, and everybody raises their hand, and you say, now, is this a question, or do you want to tell me a story? And suddenly everybody puts their hand down. But you notice that one of the students seems just frozen, absolutely frozen in place. You know the child by name, and you call his name several times, and there's no response. The teacher tells you that he's just daydreaming, and that he does it all the time. Suddenly, he comes to and acts as though nothing has happened. Well, you just saw something that many EMTs don't ever realize seizure, and it's called an absence seizure or a petit mal seizure. Our typical patient on this is a child, and they'll just freeze. They'll just stop in mid-action, and they usually only last a few seconds. But if it happens quite often, it can be rather disruptive. Some of these children that do have a lot of absence seizures are put on seizure medications, and there is some research that suggests that kids that have petit mal seizures, absence seizures, are more likely to develop another type of seizure real quick. Your unit is paged out to a local high school track for a female seizing. You get on scene and you find a 17-year-old female patient. She is actively seizing. The coach notes that she has now been seizing for almost 10 minutes. He had a stopwatch on him and he's been timing it. You don't notice any incontinence of bowel or bladder, and the patient has a good color to her, and you note that the seizure activity is actually fairly coordinated. You also know that this is the 5th seizure call you've had on this patient in 3 weeks. Now, you'll see on this slide, I've scratched out pseudo seizures. I don't like the term pseudo seizures because pseudo, when translated, means false or fake. And these are not false or fake seizures, absolutely not. What they are is a seizure of a different origin. This is not an electrical storm in the brain, but these are of psychogenic origin. The person becomes under so much stress that they just shut down. And so a much better term for it is PNES, a psychogenic non-epileptic seizure. And again, these people absolutely, positively are not faking a seizure. The cause is a psychiatric origin. Multiple triggers to it, and usually it's some kind of stress. There's literally always a witness to the event, and the motions are quite organized. Now, a couple quick thoughts on PNES. In a pre-hospital setting, we cannot truly definitively tell whether this is an epileptic seizure or a psychogenic non-epileptic seizure. So we're going to treat it as an epileptic seizure. Some people are rather derisive about our patients that have non-epileptic seizures. I do want to make this comment real quickly. Up to 80% of young women who are experiencing a psychogenic non-epileptic seizure are being sexually abused. So just keep that in mind as you go take care of people, and maybe for the 3rd or the 4th or the 5th time that they have a psychogenic non-epileptic seizure. Just keep that little pearl of wisdom in the back of your mind. So scenario number 4, and this is actually based on a real call I had. This is an absolute real call. As a matter of fact, this is a picture of the tilt-a-whirl that it happened at. It's not taken at the time it happened, obviously, but your service is doing standby at a local event, and the tones go off for a man acting strangely by the tilt-a-whirl. You put down your funnel cake, and you and your partner head over there. You're only like maybe 50 yards away from it. So you get there on scene and you see this 30-something-year-old male, and he's standing in the middle of a crowd, and he is smacking his lips and he's pulling at his clothes. And it's obvious that he is totally oblivious to what's going on around him. Lights are on, nobody's home. He's standing upright, but he is just out of it. You try to talk to him, and he won't answer any questions. You try to take vitals, and he's not combative with you, but he pulls his arm away from you and he won't let you take any vitals, even a pulse on him. So you just kind of stay there with him for a minute or two, and then he finally kind of seems to relax. He stops smacking his lips and stops pulling at his clothes, and the longer you stay with him, the more lucid he becomes, and he tells you just this really cool story. And what you've just witnessed is a partial seizure. Now, a simple partial seizure happens in a very limited section of the brains, and simple partial seizures involve either movement of one part of the body or sensations in one part of the body. But in simple partial seizures, there's no change in mentation. There's no altered level of consciousness. The person's totally conscious throughout the event. Another type of partial seizure is this complex partial seizure. It's limited to one section of the brain, again, usually the temporal lobe, and they're associated with an impairment in consciousness, but the person doesn't go unconscious. They just have a altered level of consciousness. And the complex partial seizure probably isn't a real good name. One of the new names for it is a focal impaired awareness seizure. When these people are having a seizure, they can run or walk around, and they may have non-directed violence. So they may, if you try to grab them, they may try to shove you away from them. So complex partial seizure, aka focal impaired awareness seizure. So when we can classify our seizures, we can class them into general or partial or non-epileptic. So when we talk about our generalized seizures, that's our tonic-clonic, our grand mal seizure. And we have that full body violent jerking movement. In an absent seizure, again, usually a child, they just freeze. They just sit there staring off, totally oblivious to their surroundings. Partial seizures, we can have a simple partial seizure that is shaking of one area of the body or sensation in one area of the body. But again, with those, there's no altered level of consciousness. When we get into the complex partial seizures, now we see subtle alterations in level of consciousness, but not with the patient going unconscious. They'll do activity. Some of the classic ones are smacking their lips and pulling at their clothes. We can also group into non-epileptic seizures, the PNES, the psychogenic non-epileptic seizures. Now, these patients have a profound altered level of consciousness. They have that tonic-clonic activity, but they're not caused by that electrical storm that grand mal seizures or petit mal seizures are. They have a psychiatric mechanism. So, what are we going to do with our seizure patients? How are we going to manage them? Well, first off, make sure there's no trauma present. Make sure that especially in a grand mal seizure, that they didn't fall and hurt themselves. So early on, you always have to consider spinal mobilization. Now, if the patient's actively seizing, we don't want to restrain the patient, but at the same time, we don't want them to come to any harm. So if they're beating their head against the ground, put a towel underneath them. Don't put a pillow underneath, because that probably include their airway, but put a towel underneath or gently cradle their head in your hands. Move any objects away so they don't knock anything down upon themselves. Your goal is to prevent any further injury. Now, if prior to your arrival someone has put something in their mouth as a bite block, maybe a folded up washcloth or the old torpedo style bite blocks, get it out. Clear their mouth out. We don't use bite blocks anymore. They cause more harm than good. Every single patient having a seizure has to have their blood sugar checked. So check their blood glucose level, correct any hypoglycemia that may be present. If appropriate, and if the seizure lasts a long time, start assisting ventilations. But here's maybe the very most important thing you can do. When they start coming around, provide emotional support. Get the crowd out of the way and be there with the patient when they start coming to and talk to them. Now, should all seizure patients be transported? Well, we have to consider transporting all seizure patients. But people that have a long history of seizure and have fairly regular breakthrough seizures may want to sign a refusal. Talk to medical control, give a good report, make sure your patient's totally with it, and if appropriate, do a good refusal. Now, if you're transporting a patient who's had seizures and they're either in a postictal state or they're even come out of their postictal state, I left this in. I know this is a BLS presentation, but if we have any ALS practitioners ready, have your benzo ready. Whatever benzo you happen to use. Versed has been the benzo of choice in every service I've worked for, but we also have Ativan, and Valium works very well. If the patient's actively seizing, or if you're worried that they're going to seize again, pad your cot. Make sure that if they start seizing, that they don't hit their head against any part of the cot. They have to be strapped in just like any other patient, top straps, shoulder straps, and then the 3 straps across the chest, the torso, and the legs. Make sure they're appropriately snug, but not too tight. Again, we don't want to be restraining these patients that are seizing. So let's kind of move on and discuss syncope for a little bit. Brain. So status epilepticus is, well, it's defined as having seizures, either reoccurring seizures or one long drawn out seizure. When we're faced with status epilepticus, and this is a true medical emergency, ABC management absolutely as necessary. We're not going to be able to use our OPA. We might consider an NPA, but positioning is probably going to be enough, and possibly suctioning. But again, be very careful suctioning out of patients that's seizing. You don't want them biting down on the ANCOWR. For adult patients on the ALS level, these are actually protocols from down south. We're going to consider Versed, midazolam, 10 milligram IM. For our pediatric patients, midazolam 0.2 milligrams per kilogram IM. And again, these are from protocols down south, so we'll very specifically follow Region 7 protocols. If you're in an ALS rig, don't delay administration of Versed waiting for IV access. Go ahead, and it works very well. So we want to talk about provoked seizures. Mostly we've been talking about epileptic seizures and then the psychogenic non-epileptic seizures, but we do want to talk about seizures that are provoked or caused by something else. They can be caused by an abscess in the brain, a pus-filled pocket in the brain. Absolutely alcohol. Too much alcohol can make you have seizures, but probably as important, and people have seizures when they are long-term drinkers, when they're alcoholics and they start not drinking and they withdraw from alcohol. We'll see some very impressive and very hard to break seizures with that. Birth anomalies, again, going back into the congenital defects, brain infections, encephalitis or infections of the linings like meningitis. It can be brain trauma. Traumatic brain injury absolutely can cause a seizure. Diabetes, a patient going hypoglycemic or a patient going hyperglycemic. Febrile seizures are a very interesting category. By definition, a febrile seizure happens in a child 6 months to 6 years when the temperature rapidly rises. A little bit of controversy on that, but it's pretty squared that it's not just a high temperature, but a rapidly rising temperature. Inappropriate medication dosages. This can be from too much medications, and this can also be, especially in the case of our epileptic patients, not taking their medications. We can see it in organic brain syndromes, recreational drug use, and in my career, one of the worst ones I've ever seen is spice, the synthetic cannabinoids that are sprayed on herbs and smoked. Kind of goes in with recreational drug use, but not just limited to spice, especially things like the bath salts, the methcathinone. We can see seizures in strokes or even in TIA, strokes that resolve within 24 hours. Septic patients, we see seizures in them. Tumors, people that have, particularly brain tumors, will see seizures. And uremia, patients that are having kidney failure, will see seizures in them. And then finally, kind of my favorite one, idiopathic. We don't know. They had a seizure. We don't really know why they had a seizure. We just know that they did. Sometimes we never find. So now let's talk about syncope. And syncope is defined as a sudden but temporary loss of consciousness due to insufficient blood supply to the brain. And I always throw in with loss of postural tone, meaning you fall down also. So a good definition of syncope. Syncope can have a lot of causes. If any time we have an older patient who has a syncopal episode, we think that they maybe had some type of cardiac rhythm disturbance, or maybe cardiomyopathy, or possibly they're having a myocardial infarct or some other type of cardiac tissue disease. So on our older patients, and I don't mean a lot older, from about age mid-30s on, you have a syncopal episode, we really have to think that it's cardiac until proven otherwise. And at times we'll even think that in younger patients. There are also non-cardiac causes. A person who's profoundly dehydrated can have a a syncopal episode, or somebody who's hypoglycemic. One of the big ones we see is a vasovagal response. And we'll talk about this in just a minute, but when we talk about positioning, most of the time when people have a syncopal episode, they're standing up. That vasovagal response, this is kind of one big exception to it. Oftentimes we'll see people have syncopal episodes while they're sitting on the toilet. Very simply, they're constipated, they're trying to have a bowel movement, and they're pushing against their bowels, and causes that vasovagal response where they have a syncopal episode. So here's a couple rhythms. This gentleman on the top is clicking along pretty good, normal sinus rhythm, and boom, all of a sudden he has well, first he has a ventricular standstill, and then he has a cardiac standstill. Both the top and the bottom half of the heart stop beating. But fortunately, after only about 4 or 5 seconds, his heart regains its normal beat, so he looks pretty good. The one down on the bottom guy has a fairly normal heartbeat, but then suddenly has 4 premature ventricular contractions in a row, 4 PVCs, and actually we'll call it 5 PVCs. We'll call it a run of VTAC. Again, that can cause a syncopal episode. Up on this top slide, we see somebody in SVT where they may be beating along so fast that the ventricles don't have time to refill, and cardiac output plummets, and they pass out. Down on the bottom, this person has gone into a complete heart block, and while his heart's still pumping, it's only pumping along at about 30 beats per minute, not conducive to standing up. So that could cause a syncopal episode. So oftentimes when we have syncope, it gets called in as a seizure. People think that it's a seizure, and they call it in a seizure, and when you get there, it's not. And we can kind of compare and contrast syncope versus seizures. We can look at the position of the patient before the event. Now, in syncope, the patient's almost always standing up. I did give you that one exception of them sitting on the toilet. When they have a seizure, any position whatsoever, sitting, standing, lying, hopefully not driving a car. Now, prodromal signs and symptoms before the event happens. Well, in syncope, sometimes they get dizzy, or they have visual changes. They white out, or they black out. They get short of breath. They feel very weak right before they pass out. Seizures, we have that aura on some of them, not on all, but on some of them, and you have this odd taste in your mouth, or you see lights, or you hear sounds, or start having muscle twitching. Now, activity during the event. During a syncopal episode, when people pass out, they lay there relaxed. They just kind of look like they're sleeping. Not so in seizures. In a grand mal seizure, in a psychogenic non-epileptic seizure, they have those generalized body movements. And then finally, the response after the event. In syncope, there's generally a pretty quick return of orientation. They may not stand right back up. As a matter of fact, we don't want them to stand right back up, because they may just go right back down. But yet, when they come to, they're all the way with it, and usually going, what in the world happened? Seizures, on the other hand, the people have these post-ictal periods, anywhere 5, 30 minutes. That's kind of a ballpark. It can hit anywhere there. So that's all. A quick half-hour presentation on altered mental status and seizures and syncope. If you have any questions or comments, you can put them down in the comment section, or as always, you can drop me an email.